welcome everybody. I know Southern New Mexico residency program tends to have everybody in the same room. So welcome all you guys. This is a lecture series with Dr. Sheldon and our lecture with Dr. Sheldon as part of our series. And we will be offering a CME credit for this lecture. If you would like the credit, please put your name and credentials, the names of everybody in the room that would like it, in the chat. And then at the end, Mario will link a survey and you'll just do the survey and you will be eligible for that credit. We are going to wait and hold all the questions to the end because we have quite a lot to cover. And I just want to say thank you again for agreeing to do this, Dr. Sheldon. We really appreciate it.
Sure.
All right. Off to you.
All right. Well, let me, I guess, start sharing my screen. Well, thank you for the introduction and thank you for inviting me. I am a fairly long-term faculty member here at the University of New Mexico in the Division of Cardiology. I came and did my fellowship here from back east in 1998, and then stayed on as faculty member at the VA, and then went away for training for one more year for intervention, and came back and have been here ever since. And since about 2011, I've been the program director for the fellowship. So education is one of my things that I like to do on top of opening up arteries that are causing heart attacks. So I'm going to get started. I do have a slide with some brief learning objectives. I think you may have already seen these. I kind of edited them a little bit. What I'd like for you to all be able to do is identify some key points and things about the anatomical differences of the aortic and mitral valves. I'd like you to distinguish the stages of valvular heart disease as put forward in our society's guidelines dealing with valvular heart disease, and it tracks how to deal with those patients. I'd like you to be able to identify key findings or clinical changes that should prompt referral of those patients to someone in specialty care, as well as better explain the general management and potential options for treatment to the patient and patient's family. And then demonstrate a competency with general management of post-intervention patients with valvular heart disease. As I kind of had already mentioned to Mario and Nicole, I do have a lot of slides, and then I have a couple of cases that we can maybe do at the end if people are interested. That may be need a little bit of extra time, but we'll certainly try to answer any questions you have. So anatomy. This first slide, I think, is a good overview. The left panel here, the left cartoon, is an example of looking at the heart with the atria and the great vessels removed. You're looking down at your own heart. So the mitral valve is here, aortic valve is here, tricuspid and pulmonary valve here. Now, if you look at the right panel now, we're looking at, as if I was looking at your aortic valve, looking into your chest from the front. So anterior is here, posterior is here, the left coronary sinus, right coronary sinus, and the non-coronary sinus. And the aortic valve is, relatively speaking, a simplistic kind of structure. It does have a little bit of a fibrotic skeleton, so to speak, and there are rings of tissue at the actual annulus, the junction of the cusps, and then the sinotubular junction further up. Blood would be traveling from bottom through up to the top in this cartoon. But basically what I want you to kind of get from this is that it's a fairly simple structure. There are stacked rings of tissue, roughly circular, and that has some definite issues or underpinnings that relate to how it's dealt with surgically and now with TAVR valves. In contrast, the mitral valve is much more complex. This is a picture of the mitral valve as if it was flayed open. This would connect over to this on the left side of our heart so that the posterior leaflets are here and the anterior leaflets here. Note there are three little cusps or leaflets in the posterior leaflet. So now this again is looking at your mitral valve from the atrium down. The aortic valve is up here. You have the anterior leaflet here and the posterior leaflets with the three cusps or subleaflets. And this is probably a good ending slide on structure of the mitral valve. Is what, again, this shows the relative positions of the aortic valve. Anterior leaflet here, P1, P2, and P3 are the scallops, the cusps of the posterior valve. But this section here really points out that it is not a circle. The annulus of the mitral valve really is very much saddle-shaped and makes the dynamics of the valve as it closes and opens and the LV contracts and relaxes much more difficult. And this is almost certainly why the percutaneous options and even the surgical options are much more difficult to deal with than in the aortic position. One last slide. Main thing I want to point out here is that we all know about the papillary muscles and the chordal structures. I want to mostly point out that each papillary muscle does not just contribute chordal structures to one leaflet. They both attach to both leaflets, and that's a key thing for later on. A lot of what we'll be talking about in brief can be directly attained from the most recent ACC AHA guidelines. There are also European Society of Cardiology guidelines that are excellent. These are the most up-to-date as of this talk. So this is kind of an overview for all of valvular heart disease. And it's something that I think not only us in cardiology, but in many disciplines, we really like to break things down into ABCD or 1, 2, 3, 4 or whatever. But it's I think an important concept for you all to kind of understand is that this is a progression of the disease process to the point where they are symptomatic and it's very severe, and there's really not much other to do in valvular heart disease than to try to do something mechanically. A is just people that are at risk. They may have been referred for an echocardiogram because of a murmur or for some other reason, and they have a valve that is mildly or trace regurgitant or sclerotic, but not yet stenotic. Progressive is where they now start to have the mild and maybe up to moderate severity of stenosis or regurgitation. And C is really kind of probably one of the key places, because they are generally still asymptomatic in this category, but they meet the criteria for severe disease. And we need to be really, really watchful on how to treat these patients so that they don't fall off the edge and become unrepairable. And then obviously symptomatic severe is the last stage. So I'm going to start out with just like I think, key points about when I would ask primary care providers to consider referring to cardiology. In the mild or at-risk stage that we talked about, some people do get referred in that scenario. It's probably not a mandatory thing by any means. It ought to be followed up on at some point. We'll go over timing of these kinds of things a little bit later. But it's certainly not unreasonable to send these patients to a cardiologist for an evaluation and at least so that they're known to somebody and they can then set up perhaps follow-up studies or visits in a couple of years or a few years down the road. Mild or more severe disease, even without symptoms, we will likely want to follow and co-manage them with you. We don't necessarily have to be the one that is seeing them the most often, but these are patients that almost assuredly we would want to see them at least on a yearly basis or so, and perhaps do studies on them to assess the progression of disease. Anybody with mild or more severe and new symptoms, and by that I mean some of the classic symptoms are dyspnea, angina, certainly with aortic stenosis. You may not get that with mitral valve disease, heart failure symptoms. And I have colored here decreased exercise tolerance because particularly in some of them, like mitral stenosis, people will self kind of regulate their exertion and will say, yeah, no, I feel fine. I can do everything I used to do. But then if you really push them over the past year or two, maybe they have now can realize that now they can only walk about a half a mile when they used to walk 2 miles and feel comfortable about it. And that's an important thing for us to pick up on. If they have a combination of valvular heart disease and coronary artery disease or any other significant cardiac pathology like LV dysfunction or arrhythmias like atrial fibrillation. Any of these patients that need non-cardiac surgical risk assessment, if it's moderate or more. And I have down here obstructive versus regurgitant because just as a general principle, I want you all to understand that obstructive lesions like mitral stenosis and aortic stenosis are really the ones that cause problems with patients undergoing surgery. Regurgitant lesions like mitral regurg, even aortic regurgitation, patients tend to tolerate that with surgery and anesthesia much better. But we'd still like to be involved in these. And then if any of your patients have had prior valve innervation, whether it's balloon valvuloplasty or replacement or a MitraClip or something like that, we should be co-managing them with you. I'm not going to spend a lot of time on this. I include it for your information, but in general, obviously some of the first things that you're going to need to do as far as a workup for valvular heart disease is transthoracic EKG, and obviously a history and physical are important. Most of the rest of these things, the transesophageal echo, the cardiac MRI, catheterization, obviously, are things that we're going to be dealing with and doing after we've evaluated the patients that you've referred to us. So let's start out with aortic stenosis. How do we measure aortic stenosis? This is a picture of an echocardiogram showing the velocity envelope through the aortic valve. We have a probe at the patient's chest, looking at the apex of the heart, looking up through the left ventricle here. Hopefully you can see my arrow moving around here. And the aortic valve is right here. We're measuring the velocity of those blood vessels or blood cells that are going through that valve. And this is a picture of those velocities. And the scale is over here, 1 meter per second, 2 meters per second, 3 meters per second. The bottom line is what we're looking at is the mean gradient is basically a line drawn around this envelope. And then the computer takes an integral and it gives you what the mean gradient over that ejection period is. That's an important aspect of what we are using to grade severity of aortic stenosis. It's not the only thing, but it's probably the main thing. And the bottom line is echocardiogram has become the gold standard in evaluating valvular heart disease, particularly AS, MR, and even MS. So in the cath lab, we do it slightly differently. We're trying to get at the same thing. The top panel is of a normal, healthy heart with normal aortic valve. The black line here is the pressure tracing in the left ventricle. The gray line here is the aortic tracing. We have a pressure sensor in the LV and a pressure sensor in the atria just above the valve, or excuse me, the aorta just above the valve, and we can compare those two directly. The bottom panel here is depicting aortic stenosis. The LV pressure is significantly higher than the aortic pressure. And the area between these two curves is now representing our gradient. We have to take that gradient Again, kind of take the integral of that area to find out what the mean gradient is over that ejection period. And then we have to have some other information from a right heart cath. We need to get the cardiac output and be able to plug that data as well as oxygen consumption into a formula called the Gorlin formula, and that spits out an aortic valve area. The bottom line is this is becoming less and less a part of our evaluation for aortic stenosis because there's multiple areas for error to creep into that calculation, and echo is obviously non-invasive, so that's one of the main reasons why echocardiogram has become the gold standard for assessment of that. There may still be room for this kind of procedure when there is equivocal data from the echo. So just a little bit of background, the vast majority of aortic stenosis is calcific and age-related. We see patients in their late 60s, 70s, 80s, and above presenting with kind of typical calcific aortic stenosis. But bicuspid aortic valve is another thing that we see relatively frequently in patients. They're usually presenting with AS younger, in their 50s, perhaps even sometimes in their 40s. And it brings up a little bit of nuances in how we can deal with those, particularly with respect to percutaneous replacement or TAVR. Rheumatic AS is quite rare, and if you ever have somebody say they have rheumatic aortic stenosis, but they don't have mitral valve disease, it's probably not rheumatic disease. That's always come, if it is rheumatic AS, it always comes with mitral valve disease. And again, the hallmark symptoms for AS, angina, dyspnea, syncope. Once these are present, time is really of the essence, and we really need to intervene on those because their mortality dramatically changes over the coming 6 to 12 months. Again, a little plug-in for really getting a evaluation of their exercise tolerance. A stress test when in question is a reasonable thing for to attain that, and we do that relatively frequently. A brief word about a condition called low flow and low gradient AS. You may or may not have heard about this. Basically, if your heart for some reason is not pumping adequately to generate the large gradient that we see in patients with severe AS, that patient may still have severe AS. Just because they don't have the gradient that makes it to that grading doesn't mean they don't have severe AS. What we then typically do is give them something like dobutamine to enable them to increase or augment their cardiac output or their flow through the valve. And if the gradient then goes up and reaches that severe mark, then they have severe stenosis. But if it doesn't, essentially what you're doing is enabling the heart to more efficiently pump and increase flow, and the valve is still able to open up adequately, and it's not aortic stenosis, but it's pseudostenosis. And if you stick around for a case later on, I'll have an example of that. So again, criteria for stages, I'm not going to go through these, but normal or at risk is the velocity through that valve is less than 2 meters per second. These are patients that may have sclerosis or bicuspid valve. Mild is probably somewhere between 2 and 3 meters per second, and moderate AS is somewhere between 3 and 4 meters per second, or mean gradients of up to or less than 40. Once you get to 40 or above of a mean gradient, that's when we start characterizing them as severe, even if they're asymptomatic. Again, once they are severe, we really start to be very concerned about letting these patients go much longer without intervening as long as we can, because there will be progressive things to occur in those patients, like dysfunction of their LV, congestive heart failure, and even an increased risk of death. So this is severe with high gradient. This is a severe with low flow, low gradient. And as long as we can show that it is indeed severe, they have a good indication for them to be called severe and have an intervention. And this is a slide that I have in here in the AS section, but it's actually appropriate for any of the valvular lesions on the left side, aortic stenosis, regurg, mitral stenosis, and regurg. When to be looking at these patients with echocardiograms and clinical reevaluation. So mild, probably no more than every 3 years or so. And in mitral regurgitation, it's a little bit lower. Once they reach the moderate severity, it probably should be, all of them should be in the 1 to 2 year range. I see these patients at least once a year and have an echo at least every other year for them to be reassessed. Once they're severe, even if they're asymptomatic, really our threshold to see them at least every 6 months to make sure that we are not missing symptoms and we're catching them in the time frame that we can intervene successfully. Medical management for aortic stenosis, very little. Hypertension control, if they have concomitant coronary artery disease, you want to have them on guideline-directed medical therapy. We used to think that statins could stave off the progression of aortic stenosis, but that data has been fairly well disproven, and there's really not. If they have a reason for a statin for another indication, certainly, but statins just for AS is not something that's really indicated. But ultimately, medications will always fail. You cannot treat medically a patient that has a severe obstruction to their LV outflow. So this is a busy slide, and I'm not going to go through it too much, but these top ones with the green colored are all class 1 indications. So everybody agrees that these are reasons for patients to have valve replacement. And we don't really think about valve repair. Balloon valvuloplasty is a very temporizing measure, and they typically have the same problem again within the coming 3 to 6 months. So when we're talking about aortic stenosis treatment, mechanically, it is a valve replacement. In the asymptomatic patients, there are a few things that can tip you over, and the bottom line is the data is getting better and better that says that we should be intervening on these patients earlier. There was a fairly recent couple of trials in the last 2 years where they actually looked at treating patients that were severe but asymptomatic. The bottom line is their outcomes were better. So, even the asymptomatic but clearly severe valve stenotic, aortic valve stenosis should be treated aggressively. I put this in for your perusal a little bit, but I'm not going to go over this slide in particular. And then how do we choose what to do with these, whether it's surgical aortic valve replacement or transcutaneous aortic valve or TAVR? It's based largely on their surgical risk. Certainly when TAVR first came out, the only patients that ever got a transcutaneous replacement was the very highest of risk patients. But as time has gone on, the more and more trial data, we're now almost 15 years from the beginning of these in patients. We're seeing more and more that we should be putting these in or offering them to patients that are even in the low risk category. But surgical would certainly be indicated if they're having a concomitant bypass, or they need a mitral valve replacement or surgery, or if you need to replace the aortic root because it's dilated or aneurysmal. You ought to consider doing a surgical valve replacement, in particular a mechanical, in someone who has a life expectancy of greater than 20 years. For instance, if I needed a valve, I'm 57, I would hope that I'm going to be able to live until I'm late 70s. I might opt for a mechanical surgical valve because that is more likely going to last greater than 10 to 15 years. But ultimately, it's a shared decision-making process between the patient, the surgeon, referring cardiologist, et cetera. Now, again, I touched briefly on bioprosthetic versus mechanical age. Again, I probably wouldn't put a mechanical valve in a patient that was 78, thinking that they're probably not going to outlive their valve. That a bioprosthetic has the advantages of not having to have anticoagulation. And another advantage is that you can actually do, if you needed to, a TAVR procedure inside another bioprosthetic valve if you had to. If patients have warfarin contraindications, or if it's just their patient preference. And again, shared decision-making between the whole team. And this you'll see pretty often in a lot of things in cardiology now is the heart team approach. We actually have a scheduled meeting with surgeons, non-invasive cardiologists, and us interventionists twice a month here to talk about some of these more complex patients, but everybody gets to weigh in with equal voice. And this is just put in there some of the aspects of what goes into surgical risk assessment. Frailty, there is a database called the STS, or Society of I can't remember. It's basically the CT surgery society, like ACC is for us. And there's a risk calculator that you can plug in all these parameters, and you can calculate what their risk of mortality is, prolonged hospitalization, et cetera. So anything that with a greater than 8% risk of death is considered high risk. Less than 1% would be low risk, and in between is intermediate risk. But frailty, other disease, sometimes there may be specific things about the anatomy of the patient that may go for one or the other. But that's just an example of how those things are looked at and come up with. These are pictures of mechanical valve. The two on the left here are old. This is the Star Edwards, a ball and cage. The pressure would come up, the ball would move up here and allow the blood to come around. This is a single tilting disc. These are the modern ones now. These are bi-leaflet. This one's a St. Jude, and this one is an Onyx. They basically work with two hinged kind of semilunar valves that open like this to allow the blood to come out. These had a lot of problems. This one here, the Bjork-Shiley, would actually have fractures of the structure here, and the disc would embolize every once in a while, which would never really be a great outcome for the patient. These are bioprosthetic valve samples. The only difference is there's metal in this one here. This one is called stentless. And this is the surgical ring that is sewn into the aortic root. These are the most common TAVR valves that are present. Edwards is the daddy of them all. These are the children afterwards. This is called the core valve. It's been around for 10 years. This has been around for 15 or more years. And a new kid on the block is the Lotus, which is still kind of rarely used. Edwards still probably has 80% of the market at this time, and the best data outcome-wise. Follow-up for mechanical aortic valve patients. You're looking for a goal INR of 2.5. There's still no role for any DOACs. We obviously like to be able to use that, but at this point, there's no data to support it at all. And concomitant aspirin, if they do have coronary artery disease along with that, it is a class 2 recommendation for that. Clinical follow-up for these, once they're probably 2 years out from their surgery, a lot of this can simply be done in the primary care setting and with a periodic echo, maybe every 3 years or so, and maybe a check-in with the cardiologist. But generally speaking, these are very well, they last a good long time. And transthoracic is the standard way to use these. Bioprosthetics. Used to be when I trained initially that everybody got at least 3 months of warfarin. That's generally falling out of favor. These do get aspirin if they have another reason to be, but even with a standalone SAVR or TAVR, they should definitely be on aspirin. And clopidogrel for 3 to 6 months if they have a low bleeding risk, especially in TAVR. Follow-up, again, similar to the mechanical one, they are tolerated after the first couple of years and do very well, perhaps with echoes every couple of years and a visit with a cardiologist. But I think this is excellently managed in a primary care setting. The only caveat to that is if they've had a TAVR, they need to be seen by a cardiologist on a yearly basis. We're still gathering information on the longevity of these procedures. So let's move on to the mitral valve, and I'm sure there's questions developing, but again, I'd like to hold that to the end and we can come back. I'm going to start with regurgitation, and I just want you to kind of, I guess, understand that there's two main types of mitral regurgitation. There's primary, which is essentially a problem with the valvular leaflets themselves or the subvalvular apparatus. By the subvalvular apparatus, I mean the papillary muscles and the chordal structures. This is a problem with the leaflets itself. Secondary MR, the valve appears fine, but the main issue is dilatation of the atrium, dilatation of the ventricle, and remodeling, giving you a kind of a change in the geometry of the LV that causes inability or insufficient coaptation of the valve leaflets, so you have regurgitation. And you really can't tell these on clinical grounds or sometimes even on transthoracic, but TEE is usually the main way that we make sure that we understand this. And there are differences in how these, it's not just we want to come up with another characterization. There are differences in how we have to treat these patients a little bit. This is a cartoon that you can look at a little bit later. Basically, the upper ones here are primary MR, the lower ones are depicting secondary MR causes. And this is a good slide to kind of pause on, and particularly, this could probably be a curve in any valvular disease. We really want to try to decide what the optimum timing for the replacement or repair or whatever is going to happen. They can have the onset of severe mitral regurgitation and not have any symptoms, not have any deleterious effects on their LV or even their hemodynamics. But it's a very slippery slope. Once they start to dilate and they start to have LV dysfunction, especially in mitral regurgitation, much of the reversal of that LV dysfunction is gone. The LV starts to get fibrotic, and even if you repair the lesion by repairing or replacing the valve, that LV dysfunction is going to stay. They may still have symptoms because of that. So we spend a lot of time and effort making sure that we try to find the optimal time of surgery before they get to the point where their LV starts to dilate. That's probably one of the main things. In aortic stenosis, in contraindication to aortic stenosis, if they do have LV dysfunction from aortic stenosis, they often will improve. You're releasing the obstruction at that LV, but not in MR. So these are hemodynamic parameters that we look for. MR is very difficult to grade. Even experienced echocardiography readers argue about severity of MR. There's lots of different criteria that we use, and that's why they've been developed, because we want to use more than one criteria. Because again, we want to try to catch these asymptomatic severe MR patients and intervene earlier before they get to that severe symptomatic point. Medical management for regurgitation. Again, ultimately, replacement or repair is typically what is needed, but certainly hypertension control. They're going to be more symptomatic and have more regurgitation if their blood pressure is 170/100 as opposed to 130/80. The old adage used to be you had to have them on an afterload reducer. The problem is you will never be able to reduce their afterload, say with an ACE inhibitor or hydralazine or something like that, that is usually targeting afterload enough to reduce the amount of regurgitation. If you think about it, the left atrial pressure is, even when it's overloaded, is probably in the mid to high 20s. And unless you lower the mean aortic pressure to the mid to high 20s, you're not going to appreciably change how much blood is being regurgitated. What you can do by a good blood pressure control is stave off a little bit of the progression of that. Guideline-directed medical therapy for concomitant CAD, diuretics can certainly be helpful in managing these patients. But again, I can't drive home enough that we need to intervene before the LVEF drops and or dilatation begins. Reasons to intervene with regurg. I'm going to, again, allow you to kind of peruse these on your own. You should have my slides. If you don't, I will certainly send them for you to look at. These are directly out of the guidelines. So the key things I have here on the left is repair for mitral regurg is always preferable if it's feasible, especially in asymptomatic patients. But there are definitely patients that you might not be able to repair. Replacement is what will need to happen. And this one right down here, severely symptomatic patients with primary severe MR, note it's primary, still the data is out on secondary MR. These are candidates for the mitral clip, which is a percutaneous procedure to essentially reduce the amount of MR. The procedural treatment, as we've already kind of alluded to, surgery. There's simple annuloplasty, which is a ring around the annulus of the mitral valve, which kind of cinches it up and may reduce greatly the amount of MR. There's a thing called the quadrangular repair that the surgeons will do, and I'll show you in a picture here a little bit later on. And ultimately, sometimes these patients can't have that or don't respond to those repairs and need to have a replacement. Replacement valves are very similar to the valves I showed before, mechanical and bioprosthetic. They're just sized a little differently for the mitral annulus as opposed to the aortic annulus. And then there's the mitral clip. Again, I alluded to this already. Primary MR is more amenable to the mitral clip use, but secondary, there are still some pretty firm believers that this may be something for the future for those patients as well. So I have recall one of the pictures I had of the anatomy of the mitral valve here. This is the anterior leaflet, posterior leaflet. So the annuloplasty is just a ring that essentially mimics this circle here, this black line, the outline of the annulus, but it's slightly smaller, and it basically cinches everything in and allows perhaps the poor coaptation because of dilatation of the LV to be able to now coapt nicely and greatly reduce the MR. However, sometimes there's a particular area of the valve that is causing the MR. And what the surgeons will do, I drew in a little red freehand little quadrangle. And what they do is excise that and then reoppose this side to that side. So not only is it causing the annulus to be a little smaller, but it actually is taking out the diseased portion of that posterior leaflet and enabling the valve to be competent again. And again, repair is always preferable to mitral valve replacement. Replacing it with a valve changes so many things with that complex anatomy that it makes outcomes significantly worse if they have to have a replacement. Now, this is a picture of the mitral clip. This is a device right here that stays in the patient, the white mesh covering thing. Basically, it's pushed through the atrium down into the ventricle, and the valve leaflets are caught by these wings on the mitral clip to essentially not allow those leaflets to go apart. And if you're thinking, well, actually just creating mitral stenosis, the answer is yes, a little bit. We're preventing as much MR, but we do sacrifice. We have to worry about that, that we don't create it. We cinch it in so much that we create mitral stenosis. This is probably a little bit better depiction of the actual surgery. Coming up from the IVC, we cross the atrial septum here with a transeptal puncture. And then this is the device that comes in, has the clip. You poke it through the valve into the ventricle, and then allow it to grab those leaflets in the spot. You can do this during TEE guidance, so you don't cause too much stenosis, or that you are actually repairing the mitral regurg, and this is the end result. You have a clip that stays in there. It's free on the tips, and it's not attached to anything but these leaflets. And again, I have a case later on if we can, if people want to stay a little bit longer, I can show a patient with mitral clips. So mitral stenosis is our last more common lesions that we're going to talk about. It's not common really that much anymore, and it's getting less and less common here. For it to be really a thing that you see commonly, places like India, Pakistan, there are other places where it is more of a problem, and you see a great number of these patients. We see these sporadically. Often these are patients that have come or originally came from South or Central America or other lower middle income countries. It's more common in women, and it's largely in our practice at this point a disease of 50 to 70-year-olds. If you were to travel to, say, India or Pakistan, you might see patients that are in their 30s or 40s with rheumatic valve disease that are severe enough to be intervened on. As we see them older, they often have more calcification and fibrosis of the leaflets and the subvalvular apparatus, those chordal structures and the papillary muscles, which causes some problems. Calcific, pure kind of calcific mitral stenosis, where there is no history of rheumatic fever, is uncommon, but becoming a little bit more common. These are patients often that have annular calcification to the point where it starts to impede the movement of the leaflets themselves. This is a little cartoon. The left panel is normal heart, depicting nice, fairly thin, mobile mitral valve leaflets. This is a patient with rheumatic mitral stenosis. Looking at it from below, or excuse me, from the atrium. So you're looking down at the valve here. This is the anterior leaflet. These are the posterior leaflets. This is fairly normal here. This is thickened with rheumatic fibronodular deposits, and the commissure, the actual place where the valve leaflets come together, starts to fuse. And now you have a stenotic valve opening. Again, going through the stages, at risk, where we might just see a very little mild abnormal motion of the valves, but no real stenosis. Mild stenosis is getting to the point where your mitral valve area is calculated by certain parameters, is approaching 1.5 centimeters. Anything less than 1.5 centimeters is considered severe, and severe is usually even smaller, and you often have very symptomatic patients at this time. Again, C is where we want to concentrate a lot of our efforts to try to intervene early rather than late. And this is a classic patient that will come to your office and say, yeah, I feel fine, but they have severe mitral stenosis based on an echo that you got a month ago. And you ask them about their exercise tolerance and say, oh, I can do everything I used to do. And then maybe their spouse or Partner says, no, I don't think you do. And you put them on a treadmill and they can only go about 2.5 minutes on a exercise treadmill. It's very telling, those patients that need to have those interventions. And that can be a very nice objective way to try to find them. The workup, obviously transthoracic is the main way that we do this. If they're potentially eligible for a balloon, so percutaneous mitral balloon commissurotomy is the technical term. We call it just valvuloplasty, mitral valvuloplasty. A TEE, transesophageal echo, needs to be done to make sure that they're eligible for that. And there's some criteria that I'll go over. Again, exercise testing for those patients that it's equivocal whether or not they have a change in their exercise tolerance. Medical treatment, the mainstay is that if they have concomitant AF or they've had a prior potentially thromboembolic event or cardiothromboembolic event, they have known left atrial thrombus, they should be on anticoagulation. No ifs, ands, or buts. And at this point, remember, it's not DOACs, it's warfarin. This is the classic valvular aortic stenosis, or valvular aortic atrial fibrillation that needs to be treated with warfarin, not a DOAC. And rate control I have highlighted here because that actually can help in the symptomatic patients, because if you think about it, if someone is going 100, their left atrium is not able to have enough time to empty into the left ventricle so that the pressure in the left atrium can get to a point that is not severely or significantly elevated, causing them to have symptomatic, perhaps pulmonary edema, or at least the elevated pulmonary wedge pressure. If you slow them down, they actually have a longer diastolic filling period from the left atrium to the left ventricle that they actually can lower and rid themselves of that high gradient. So in that case, when patients are either in sinus, but they're tachycardic in the 100 to 100 plus range, or certainly if they're in AFib and they're running on the higher side, slowing them down with a beta blocker is potentially very helpful for that patient. The problem is sometimes you can also cause them to decrease some of their cardiac output to the point where they start to become symptomatic from that. So it needs to be done very carefully. Definitive treatment comes in two forms, as I said, valvuloplasty and surgical commissurotomy. And ultimately, obviously, replacement, as we talked about with MR, but again, they're going to try to avoid valve replacement as much as possible. This is valvuloplasty or balloon commissurotomy. Again, coming up from the inferior vena cava through the right atrium, a transeptal puncture. This is a special balloon, formerly called the Inouye balloon. That was a particular manufacturer and who it was designed after initially. Now there are different manufacturers that make the same balloon. There's one balloon inside that anchors you in the place, and then you have the definitive balloon that basically just cracks open those commissures and allows the valve to actually start to open up a little bit more freely from being stuck together, so to speak. And surprisingly, this works quite well with some caveats. It doesn't necessarily work very long lasting in the aortic valve, but this does work in the mitral valve. The problem is there are some no-goes that you cannot do this procedure. If they have moderate MR or worse, you cannot do it because you're just going to make that MR worse. Or if they have left atrial thrombus, you cannot put equipment in there. You certainly have a high chance of embolizing that. And then there's something that's called the Wilkins score that we can do on a transesophageal echo. This assesses the valve status as well as the subvalvular apparatus. And it's based on these scores: leaflet mobility, valve thickness, subvalvular thickening, and then valvular calcification. Bottom line is, takes a fairly experienced operator to kind of do these gradings. Usually it's done, as I mentioned before, in kind of a heart team approach, where patients are surgeons and interventional cardiologists and non-invasive cardiologists get together and kind of come to a consensus on the score as to whether it's reasonable to pursue a valvuloplasty or not. Bottom line is a total score of 8 or less makes it amenable, as long as they don't have either of these, for a valvuloplasty. If it's more than 8, they should have surgical commissurotomy or replacement. Again, this is just another from the guidelines here. I'm not going to go through these. You'll be able to go through yourself. The bottom line is things that in asymptomatic patients that may push you to doing definitive interventions more or earlier rather, especially if you can do a valvuloplasty, are presence of pulmonary hypertension or new AFib. Those are both triggers in your mind that should say, all right, maybe we ought to consider doing this even though they are asymptomatic with severe mitral stenosis. Again, mitral valve, if they get a mechanical valve, warfarin goal, it's warfarin, not DOACs again, but the goal INR is higher. This is a lower flow or lower flow velocity state, or because the orifice is bigger, and therefore the thrombogenesis is a higher possibility there. So the INR is needed to be higher. The goal is 3, so 2.5 to 3.5. Concomitant aspirin, I tend to say yes, certainly if they have concomitant coronary artery disease, but there are lots of cardiologists out there that would say no aspirin with this. These are patients that I think would be best followed by a cardiologist, but certainly can be co-managed with primary care and maybe alternating visits to make sure that the mechanical valve is holding up and they are having no change in symptomatic status. And again, echo transthoracic is the only real way to kind of look at these patients. If they get a bioprosthetic valve, your goal INR for about 3 to 6 months, and that's pretty standard, is 2.5, a little bit lower than the mechanical ones. Still, again, no role for DOACs, and concomitant aspirin is kind of the same discussion we just already had. Again, cardiologists, I think, should be involved with these patients. These bioprosthetic valves do not last anywhere near as long as the mechanical valves, especially in the mitral valve position. They take a beating. There's a big gradient between the left ventricle and the left atrium. And because of that, there is just more wear and tear on these valves, and they tend to wear out quicker than the aortic valve. Prosthetic valve follow-up. I promised you I'd get here at some point. We'll go through these one by one here. These are certainly anybody that gets surgical or transcatheter valve replacement. They have to have an initial post-procedural TTE, and then usually within 5 to 6 months afterwards. And then any change in symptoms at any time during those patients should warrant an echocardiogram order and follow-up. They're talking about here, if it's equivocal, then there are other things that you can use like TEE, sometimes gated cardiac CT or fluoroscopy can be used to see the valve leaflet, particularly mechanical opening. The question mark I have here is they actually say TTE only 5 to 10 years after their first year or so. We go a little bit more aggressive than that, would say that probably at least every 3 years, these patients need a transthoracic to make sure that their bioprosthetic valve is functioning well. And the other thing on the bottom of this that's very important is if they've had a TAVR, transcutaneous replacement, an annual transthoracic is recommended, and they have to see a cardiologist every year. These are still relatively new devices that we need to be involved with. And there are some things that can happen in these valves that are not seen in bioprosthetic surgically implanted valves. All right, last couple of slides here, and I think I'm not too bad on ending. What to do with antibiotic prophylaxis. You guys, I'm sure, get these questions all the time from dental offices or anything like that. So what patients are at risk? The vast majority of valve disease patients do not need prophylaxis until they have a prosthetic valve or some material in there. So anybody that's had a prosthetic valve, whether it's surgical or percutaneous, if they've had a repair, if they have an annuloplasty ring or a mitral clip, they should have antibiotic prophylaxis. Certainly anybody with a ventricular assist device needs to have antibiotic prophylaxis. If they've had previous infective endocarditis, and that's even if they haven't had a valve replacement or repair with a device. And then anybody with cardiac transplant with acquired valvulopathy should get antibiotic prophylaxis. But I think this is a little bit of a surprise to some people that, you know, even if you have severe aortic stenosis, but you're asymptomatic, there's not a good indication for you to be on antibiotic prophylaxis for a dental procedure or whatever. What procedures? Again, dental procedures, anything that involves manipulation of gingival tissue, so that it does include a cleaning. Respiratory tract procedures and procedures on infected skin or skin structure. And then surgery to place a prosthetic heart valve or a prosthetic intravascular or intracardiac materials is it's certainly recommended. And again, I think surprisingly to some people, it does not mean you need prophylaxis with genitourinary or GI procedures. So I know that was a bit of a whirlwind, and I'm sure I rushed through some of this, but I will. I guess this is, I think, a very good bibliography. The ones I have green arrows next to, I think, are particularly good and might be helpful for those who are interested in further reading on any of these topics. So I will stop sharing my screen for right now, and I'd be happy to entertain questions from anybody. Okay, now I guess I'm not hearing too many questions. If there's anybody interested in seeing a couple of cases that I have, it's basically kind of show and tell. I can describe it a little bit. I can go a little bit further, or we can all go our separate ways and get to our Wednesday afternoon.
Dr. Sheldon, will you be able to share those slides?
Yeah, I can send them to you right after this.
Okay.
You should already have them, but there were some updates, some minor updates. So.
Okay.
Thank you for your time today. We really appreciate it.
Sure. Hopefully it was helpful for you.
Yeah, thank you.
All right. So with that, I will go ahead and close this out since we are at 1 o'clock now. Coming up on June 1st, we have a faculty development webinar with Dr. Daniel Stelberg of UNM, who will be talking about teaching to adult learners and precepting tips. And then on June 22nd, we have a didactic series lecture with Dr. Nora Lamartine of El Centro Family Health, who will be covering pregnancy and diabetes. So with that said, thank you all for attending today.